So how many people enjoyed playing with Atlas? Raise your hand. That's super cool. And how many people enjoyed playing with criteria to query? Most of the same hands.
How do you define enjoy?
You've chosen to come on a Sunday afternoon when you could otherwise be watching football. Was this better or worse than sitting in the bar watching football? I feel like this is worth good fun. Have a little bit of I guess an option for you guys. So there's two topics that we thought to want to cover. We do have a hard constraint that we need to be done at 5. Just curious, how many people are staying for the Women of Odyssey Leadership Forum that's taking place this evening? Did I hear a woo? Woo, okay. So for those of you who don't have your hands up, just so you know, there is a Women of Odyssey Leadership Forum event that's taking place. It's open for everybody. It's actually taking place in this room starting at like 6:30. And we have distinguished leaders in the field that are coming to share their thoughts and perspectives. So it's going to be a wonderful event. Because of the fact that that event is physically in this room, I have to stop talking at you at 5 o'clock because they're going to come and we got to get out and they're going to move the new stuff in. So in the interest of time, we've got really two things that we could talk about. One is the notion of phenotype evaluation, which this is what Joel Swerdell was going to present on, and I'm happy to present on his behalf to talk about the idea of how to evaluate phenotypes. The second thing is to discuss ongoing activities in the community about how we are trying to build a phenotype library and this idea of sharing phenotypes and our current thinking about that, which we were hoping to have a little bit of discussion on. So I'm just interested, maybe a show of hands, how many people would like to hear about phenotype evaluation? Like, okay, that's about an even split. And how many people would like to talk about phenotype library? Okay. All right. So more people want to hear about evaluation, and there's like a third of you over there that seem like you're just done with the class. And that's okay. Hopefully, I know there's enough that's enjoyed it that's okay. Or maybe it's just that you really enjoy playing with the tools and you just don't want to listen to me, and I think that's probably a good character judgment. In either case, so why don't we talk a little bit about evaluation? And what I'd like to do is set up the problem of evaluation in terms of how what we're seeing is a challenge for the field at large, and to introduce you to some of the innovations that are going on in the Odyssey community that we think really could hopefully hopefully make progress towards this space. To tee this up a little bit, how many of you, when you were making your cohort definitions for this exercise, how many of you felt confident that you definitely had the right answer? Show of hands. No? How many of you are confident that you definitely had the wrong answer? Okay. Well, at least partial right, partial wrong. Actually, I guess I'd be because Thomas actually asked about this. Maybe I can go through evaluation, but would folks like to go through those two cohorts together to talk about what was done? Raise your hand if you would like to go through the two cohorts. All right, that's fewer hands than want to hear about evaluation. So we will do evaluation first, and if there's time, we'll go back and look at those cohorts, okay? So evaluation, the general notion here is that your experience of not being 100% sure that you got the right answer is a bit of a trick question, because there is no right answer to a cohort definition. A cohort definition is an explicit piece of logic that identifies a set of persons who satisfy a criteria for a duration of time, because that's what a cohort is. And on the basis of that, it is not that there is one right way to define any particular disease or any particular drug. There's lots of ways to define diseases and drugs. And in fact, the challenge that we actually see is that we oftentimes see that people think that there is going to be one aspirational correct way to do it, and therefore argue with each other about the merits of which one is right or which one are wrong. I can tell you that I personally have spent, and my team that's here can vouch for this, they've had the same shared experience, that I've spent hours, which is probably now morphed into days, which is probably now morphed into weeks, arguing with clinicians about an ICD-9 code list. And I can tell you that very, very often in that experience, we're arguing about whether or not to include a code, and that code doesn't even appear in our data, which means we are just 100% wasting time. And yet, this is what we do. As epidemiologists, we pride ourselves on being monotonous in these types of endeavors. So the truth of the matter is that there isn't a right or wrong code set. There isn't a right or wrong cohort definition, but instead there are alternative cohort definitions that are attempting to get to the same answer. And that same answer is that clinical idea that you have in your head about what you're trying to get at. And for each one of those different ways that one could think of creating a cohort definition to try to implement that phenotype idea that you have in your head, the question becomes, how well does that definition do at finding the people you want and not finding the people you don't want? And how well does that definition do at figuring out the correct index dates for entry into the cohort? And how well does it do at finding the correct exit dates for leaving the cohort? And so all too often we spend our time creating cohort definitions. But then, once we create a cohort definition, our minds go crazy. We just assume it must be perfect. And we move on with the rest of our research as if that definition we've just created is a one-to-one correspondence to that idea that we have in our head. But in fact, we know that our definitions are imperfect. They're imperfect because you guys just experienced not being sure exactly what logic you picked. They're imperfect because codes can change over time. They're imperfect because doctors don't enter all the data in for a patient into the electronic health record. They're imperfect because patients don't go to the doctor when they're sick all of the time. They're imperfect for all sorts of reasons, which means whatever cohort definition you create, it is going to be an imperfect representation of that clinical idea that you have in your head. And very often, we've seen in the community that we are either expecting that we're going to create a cohort definition that perfectly matches our clinical intuition, or we realize that it's imperfect and we feel like, well, what kind of research can we do if this thing is imperfect? I'm going to instead try to pivot this conversation to actually say, measuring the level of imperfection, that is quantifying the measurement error in your cohort definition, is not a weakness of cohort definitions at all. It's actually a strength and an opportunity that we have as a community. And by having the ability to measure the performance of a cohort definition, that actually for the first time provides us a tool to compare alternative cohort definitions for the same idea. And from that perspective, it's not a matter of whether one definition being right or wrong. It's a matter of that if we all as a room came up with many different ways to define, what'd you guys just do? Hydrochlorothiazide users for high blood pressure, that if we all had different ways of thinking about tackling that problem, we could empirically test those ways and figure out which definition achieves better operating characteristics, here defined by sensitivity, specificity, and positive predictive value. So what I'm going to talk about a little bit is just motivating this idea that phenotype evaluation is something that I actually feel very strongly is actually the future of where all of our observational research is going to be going, and to introduce to you a tool that's actually going to make it possible for you to do that right now in your data, as long as it's in OMOP Common Data Model format. Okay. So there was this paper published a few years back in JAMIA that specifically was trying to describe phenotyping of drug-induced liver injury. This is a paper that several authors, including some in the room, were a part of. But we highlight this paper actually because it provided some definitions that I thought might be useful for this. So when we talk about a case definition, what we're really doing is describing characteristics that a patient must possess to have a disease from a clinical perspective. So it's that clinical idea that you've got in your head. What would you need to be able to observe to see that, to consider that person to be some sort of definitive case? And what we've been talking about, what we worked on just now, is a cohort, to develop a cohort definition or a phenotype algorithm as defined here. It's just the translation of that clinical idea in your head, that case definition, into that executable algorithm that involves querying the clinical elements. Reason sharing this again is to help you think about what you just did. You just created a phenotype algorithm to represent the clinical idea that happened in this case to come from clinicaltrials.gov. The question is, how well did your implementation work at finding those cases that you were targeting? So the real question that we're asking here is, like, how do we know if our cohort definition is any good? Did it actually perform the task of doing the translation of that clinical idea down to patients with some level of confidence? And if we're going to measure performance, we probably need to understand, like, what's our goal for performance? We may say that we have an aspiration that we're going to be able to have a perfect definition that's going to find us all the people that have the disease and none of the people that don't. But realistically, because we are mostly dealing with observational data that's not captured for research purposes, that has lots of noise due to the healthcare system and the patient's behavior, perfection is probably not the realistic goal that we're going for. Instead, what we need to think about is, what is our aspiration of what we are trying to achieve when we create some sort of definition. And we'd also like to be able to think about whether our cohort definition is actually generalizable across sites. We talked earlier today with that one cohort definition that we talked about the generalizability of the population we looked at. It was the dabigatran one. You saw that only 15% of the, or was the warfarin, 15% of the all new users of warfarin actually qualified for the study. That's one dimension of generalizability. Another dimension of generalizability would be, if we applied that cohort definition to different databases, would we have also seen that it was 15%? Or would it be different at different sites around the world? And of course, that's almost like an impossible question to ask, because we don't have access to all of the world's data. So how in the world, and we don't know that their data format, and we don't have a way to consistently write code that runs against that. Until now, because of OHDSI, we do have a worldwide data network. We do have a standard way to represent a cohort definition. And what that enables us to do is take that one cohort definition that you all just created, and we can send that piece of code to any database around the world. They can execute that code, and they could tell us back in seconds whether they also observed a 15% attrition in our population. So that would be nice to know. I showed this example earlier, the idea that different criteria can result in different patients being identified. What I didn't show you earlier is in that same paper, they actually tried to provide evaluation metrics to suggest how well these alternative definitions were working. And so specifically in that paper, I'll go back to the Venn diagram that I showed earlier, these circles represented different types of data elements. So think of those as the inclusion criteria that you guys were just playing with. But the table that's in the paper actually breaks it down into each of the different criteria that could be considered, and they evaluated in this one particular cohort how many people satisfied these particular criteria, and then they estimated the sensitivity and the positive predictive value. Now, sensitivity is the proportion of the true cases that you are able to identify. So in this case, for congestive heart failure, if you think of in the database, who are all the people that actually really truly do have congestive heart failure? Sensitivity, the higher that number is, the more of those people you're capturing. Positive predictive value is saying amongst the people who belong to this cohort definition, what percentage of those people truly have congestive heart failure? And so that number also can range from 0 to 1. And what you see in this particular example is different ways of defining congestive heart disease resulted in different sensitivities and different positive predictive values. No one of these definitions was necessarily best, but instead they represented trade-offs between what your objective would be. If your goal is to maximize the number of people that have congestive heart failure that you find, you can see that top definition of just an occurrence of any diagnosis code had the highest sensitivity. But sometimes your aspiration might be to make sure that the people that you find really legitimately have the disease. That is, you don't want to discover false positive cases. In which case, you might go down here and say, maybe I'll use a definition of a primary diagnosis and a laboratory measurement, and that's going to achieve a positive predictive value of 90%. That is, 90% of the people who satisfy that criteria turn out to legitimately have the disease. But you can see that for that 90%, it's only about 30% sensitivity. So in order to achieve that 90% of the people that I find have the disease, I'm only going to find about a third of the cases. Again, these are not right or wrong. They are alternative ways to think about what happens when you apply your cohort to a population. Now, what's important and valuable about this is when I know what the sensitivity and the positive predictive value of the cohort definitions are, I can make rational choices about which one to use in which circumstance. And I can make choices. For example, I could look at these numbers and say, I do not trust the evidence that I'm going to generate if I have a positive predictive value of only 40%. Or I don't feel confident that I'm finding enough cases if my sensitivity is only 30%. By knowing how well a cohort definition performs, I can make reasonable choices about how to use it, when to use it, if to use this definition. So then the question becomes, if we think it would be useful to have these numbers, how do we get these numbers? Because most research that's being done right now doesn't actually provide these numbers at all. And in the absence of these numbers, we are left to just guess at whether or not a cohort definition is actually finding the people that we want. So if it seems obvious, like, sure, we'd like to know how well a cohort definition works, like, well, why aren't we doing that right now? And part of it is because we need some sort of ground truth to be able to measure the performance. And so if you had your whole database and you could actually perfectly determine for every individual whether or not they were a case or not a case for that clinical idea that you had in mind. And if you could manually, magically, just perfectly label everybody as a yes or a no. If you had that, then it would be pretty straightforward that we could take cohort definitions, these rule-based heuristics that you guys created earlier today, you could apply it to the data set and you could just count up, create a 2x2 confusion matrix. You just count up how many of the true cases you found, how many of the false cases you incorrectly identified, and how many cases you missed. And if you had those numbers, we could estimate sensitivity, specificity, positive predictive value. The problem is we don't have magically labeled sets of people for everybody in a database. And the process of having labeling take place on any cohort is extremely time-consuming and costly, and by and large prohibitive for many of the things we want to do. What we typically see done in a lot of research, particularly like in the epidemiology field, is you identify the people who your algorithm the people who your cohort definition would identify, and then you would sample amongst that group to be able to estimate only positive predictive value. You wouldn't have the ability to look at the patients who weren't in your cohort definition to get any sense of how many patients you've missed. And so what we've been thinking about in the OHDSI community is two things. One is we know that manual clinical adjudication is still kind of considered a standard for how people think about doing adjudication. And so we've been thinking about how do we make that process more efficient. And some of you might have, those of you who came to last year's OHDSI Symposium might remember that the award for Best Open Source Software Development Project went to an effort developed out of Georgia Tech where they built a tool to actually do electronic chart review adjudication in a much more efficient manner, and that's something that we're hoping to build into the Atlas platform as we're going forward. The second thing that we've been thinking about is, well, is there some way that we could label these people in the database in some way that didn't involve humans having to actually look at every single chart and making choices? And so the work of PheValuator has actually been this idea of how can we create a reference gold standard through some probabilistic models. And so I'll talk a little bit about that. So I mentioned that positive predictive value is currently the primary metric that is obtained through manual review. And this is not because people think positive predictive value is the right thing. It's because it's the only thing you can do that if you are limited to sample the cases from the cohort definition that you've created. Sensitivity, sometimes you can try to figure out if you had some ability to sample from outside your cohort definition, but very often that's very challenging to do. And particularly when we're studying rare events, the number of samples that one would need outside of the cohort definition is so large that it's inconceivable that you could put the manual effort into that type of an effort. Now, I'm going to go back to the Graham paper that we showed earlier. And this sentence at the top, I think, is kind of emblematic of what we see in most published observational research. It says the codes defining ischemic stroke have a positive predictive value of 88 to 95%. And then it goes on, and bleeding is 89 to 97%, so on and so forth. So they provide these positive predictive values. They provide a single metric of performance, and as a result of this, as is done in most studies, is once they show that these numbers are kind of good, they then perform the rest of the study as if they are perfect. Now, if I tell you that something's 88 to 95% good, you might feel kind of good about that, right? 88 to 95%, that's kind of good, so maybe I'm okay with that. What if I phrased that same sentence in just a slightly different way? What if the paper instead said, somewhere between 1 in 10 and 1 in 20 people who have these diagnosis codes don't actually have stroke? And I don't actually know how many people who don't have a stroke actually do have a stroke, or whether any of the false negatives that I have represent any sort of differential bias. This reframing of the sentence sounds a little bit negative, I suppose, but in fact, this is what we're saying when we do a paper and we publish and we only list a positive predictive value. We are saying that our study is getting patients wrong, but we have no idea how many patients we're missing. And the only way to actually overcome this problem is to figure out a way that we can actually provide a complete understanding of the operating characteristics of a cohort definition, which is to say we need to be able to quantify sensitivity, specificity, and positive predictive value. Because if you give me only one of those things, I have no idea what the other two are. I need all three to be able to actually put my hands around what I'm actually observing. And the second thing that I'll highlight is that if I know that there's measurement error, I know that 1 in 10 of these cases are wrong, why do we have to keep assuming that it's perfect after we've learned that it's imperfect? There's actually well-established statistical methods for incorporating measurement error into our studies. Ken Rothman's Modern Epidemiology book has an entire chapter dedicated to this problem, and yet there was a recent paper, and I'll get the exact numbers wrong, but there's a recent paper that was published that did a review to figure out how many times when someone knows that there's error, did someone actually adjust for the error? And the answer was something like greater than 95% of the times there was no reference to it other than acknowledging that there is imperfection. And so I would actually posit this as a challenge to all of you as researchers, that if you create a cohort definition, I would say that you need to evaluate it to understand how imperfect it is. And it's not a bad thing that your definition is imperfect. It's a statement of reality and the statement of how well your data works. But given that you are going to learn that your cohort definition is imperfect, that's an opportunity for you to think about how to use that new knowledge you've gained and incorporate it into your study to provide a more reliable estimate. So let's walk through an example. Let's use myocardial infarction, which is one of those that Graham also did in their paper. Remember, we have two different things that we're thinking about. There's the clinical idea of what's myocardial infarction, and then there's our phenotype algorithm, which is how do we find myocardial infarction in our data. And so the WHO provided a clinical definition of myocardial infarction. It's defined as the demonstration of myocardial cell necrosis due to significant and sustained ischemia. And it's described that you can observe that through an ECG, and there's also some presentations of some specific symptoms or some history of elevated troponins. Okay. Now, that's the clinical idea. We're trying to find myocardial infarction, and that could be defined in some clinical parameters. The question is, how do we create a cohort definition or a phenotype algorithm that can go find those cases? So our friends at Sentinel did a nice piece of work where they looked at an outcome definition and attempted to validate it across the Sentinel network. And specifically, the way that they did that was they created a phenotype algorithm based off of ICD-9 codes. Specifically, they were looking for hospitalized patients with a 410.x0 or 410.x1 in the primary position. So there is a cohort definition. You've now learned that you could implement that definition yourself in Atlas if you wanted to. And then what they did was they identified a subset of the people who satisfied that rule, and they pulled out the medical charts, and they looked to see how often did the people who met that rule actually have the disease. Okay, I'm just going to skip that. So this kind of validation that Sentinel did, that is not uncommon to what we would typically see. You'd have some group of people created a definition, did some sort of validation, and produced some sort of estimate here, reporting that the positive predictive value was 86%, and it ranged from 76% to 94% on different databases. What was really interesting, though, is that this paper by Rubo et al., what they did was they actually did a systematic review of all the different groups that had tried to do validation of myocardial infarction. And so their question was like, okay, well, you know, Sentinel just did that, so presumably that's because it wasn't done before? Or is it that everybody keeps doing the same activity over and over again? You know, the definition of insanity. What they did was they did a systematic review just to find, okay, how many people have tried to define MI, and for those, how many of them actually did some sort of validation, and what did they all find when they did those validations? And what they found was they found 33 published studies where somebody posited a phenotype algorithm or cohort definition for myocardial infarction. And then for those, they reported out how did they go about doing their validation. So I've mentioned this verbally, but just to show a cartoon of it, when we talk about validating an algorithm, we have the test, which would be our cohort definition, which is either going to classify someone as having the disease or not. And then we have ground truth, which is either positive or negative. And for that, there are 4 possible scenarios. You could have a true positive if you say that someone has the disease and they in fact do. You can have a true negative when you don't say someone has the disease and they don't. You can have a false positive if you identify a person who you think has the disease but they don't actually have it. And you can have a false negative if you say, I don't think this person has the disease, but in fact they actually did. Those are the 4 scenarios that we could be worried about. So the test is going to come from your cohort definition. The truth is going to come from our gold standard, wherever that might be. And the metrics that we're going to be talking about are sensitivity, specificity, and positive predictive value. And those 3 metrics can be directly computed based on those 4 counts up top. So sensitivity is the proportion of the true cases, the ground truth positive cases that you were able to identify. Positive predictive value is the proportion of those positive tests that were actually in the ground truth. And specificity is trying to give you a sense of the proportion of true negatives over all of those who, the proportion of true negatives amongst all of those that are truly negative. So to go back to this example, Sentinel has their definition. They report the specific way in which they did their validation, which was cardiologist reviewed charts. And they reported a positive predictive value. Here's another one of those papers that the Rubo group found, a paper entitled An Algorithm to Identify Myocardial Infarction Using Medicaid Data. And what they did was they had an algorithm, which was a 410 code, and a hospital stay of greater than 2 days. So you can see it's a slightly different definition. They reported how they classified cases, which actually involved looking at someone's chart to look for their prior indicators of cardiovascular events. And then they reported a positive predictive value of 93%. Here's yet another paper published. A different definition here. We're just trying to assess the accuracy of ICD codes. I don't know which codes they are, but it's good that there's codes, I guess. They had adjudicators look at symptoms to try to figure that out. And then they reported the accuracy of the codes. Again, here it says accuracy rate, but really we're actually talking about positive predictive value. So what was staggering to me when reading this paper, so here's those three that I just highlighted, but what I'm showing you here is each of those papers in the Rubo summary, they kind of had an idea of what data elements were actually required to create the definition, and then what you're seeing is the range of positive predictive values that were estimated across all these definitions. And you can see that the range of PPVs for just one disease that I think we all kind of feel like we know. Myocardial infarction's one of the easy ones for us to do. And yet these algorithms basically range from a positive predictive value of like from 73% to 95% or so. And these definitions, everybody was basically coming up with their own take on how to find the disease. So instead of having a community of people converging on a common definition with known operating characteristics, what we had was a whole bunch of people, everybody think they're smarter than everybody else, coming up with their own little wrinkle and then reporting out some sort of statistic, and we continue to all work in our own little silos. I think is kind of a problem. The conclusion of their paper, and I think what generally is shown, is that there is no gold standard algorithm for acute myocardial infarction. So if you do a study of MI and you say, well, I use this definition because it's the gold standard approach because somebody else did it, well, I can find you 32 other papers who did it a different way who would think that they were the gold standard. Most of the summary that they talked about was the cost and the resource requirements to do this clinical adjudication, which is quite challenging. And you noticed in that plot that a lot of those validations were done on sampling. And because we sample a number of patients to handle the resource requirements, what that means is we actually have uncertainty in our estimate. So even if we're only going to estimate positive predictive value, we'd like to at least be confident about what that positive predictive value is, and yet many times we don't even have much confidence there. But probably most distressing is that there's 33 studies that all claim to be doing validation. They all reported positive predictive value, but only a third of them actually reported an estimate of sensitivity, and only 5 of the 33 reported a specificity. And so the challenge that we'll assert is is that even validation? One could say that knowing positive predictive value is better than nothing. I think I can make a mathematical argument that it's not actually better than nothing, that it's actually unhelpful altogether. Because you need all 3 of these numbers to be able to actually understand whether or not you can quantify the uncertainty and the measurement error that's going to be part of your study. So just to illustrate that point, let's think about positive predictive value as a metric. So we don't get sensitivity and specificity very much. But actually the challenge that you have is that positive predictive value is a formula that one could write down that is a function of sensitivity, specificity, and the prevalence of the disease that you're targeting. And so you actually have to know those 3 numbers in order to actually estimate positive predictive value. And if I only know positive predictive value and I don't know those other 3 numbers, the problem is that I can come up with lots of ways to jigger those 3 numbers to get you to the exact same positive predictive value. It's a basic challenge of degrees of freedom here that we're going to be struggling with. So to illustrate that, imagine I tell you that I've got 1 test but 2 populations. And the test characteristics is that you've got a sensitivity of 75% and a specificity of 99.9%. If the prevalence of the disease of interest is 1%, then this is what your confusion matrix will look like. You're going to have 75 true positives, 25 false negatives, 10 false positives. And what that will provide you is a positive predictive value of 88%. So given that I know the sensitivity and specificity, I can get a PPV of 88%. But imagine I go to a different database who has a different baseline prevalence of the outcome. Let's say that the prevalence is 5%. By virtue of the prevalence of that outcome being 5%, my positive predictive value is now 97%. I have the same sensitivity, the same specificity. All I did was just change the prevalence, and I can vary the positive predictive value from 88% to 97%. Incidentally, that's that range that we saw in that earlier paper, which raises the question, what was the prevalence? Because the prevalence would define what you're going to see. Probably what's scarier from my perspective is the fact that we report out only PPV. So if I report out and I tell you we should be good about this study because the PPV is 90%, well, what would a 2x2, what would a confusion matrix look like for a PPV of 90%? Well, if I take prevalence as 5% and I give you this particular matrix, this achieves a positive predictive value of 90%, and yet it has a sensitivity of 18%. That is, if I had 1,000 or 10,000 patients, I could have 90 true positives, 10 false positives, 410 false negatives. I'm going to only find about 20% of the outcomes, but I'll get a positive predictive value of 90%. Maybe that's good, maybe that's not. I can also achieve a 90% positive predictive value with a sensitivity of 72%. That is, I could have this same prevalence, same database, but now I could have a different algorithm that's going to actually achieve a sensitivity of 72%, but now I'm taking a hit on my specificity going from 99.9% to 99.6%. Now, why does this matter? Well, if I only report to you positive predictive value of 90%, you could either be dealing with an algorithm that only finds you 1 in 5 events, or that finds you 7 out of 10 events. That's a pretty wild difference. You do not know which one of those two it is if I only give you the positive predictive value. So the argument that we've been wrestling with in the community is, okay, everybody right now is spending tons of money to try to get this estimate of positive predictive value. And even after they get it, I'm still not convinced it's helping me at all. So what do we got to do about that? Well, we have to figure out a way so that it's not so expensive to actually produce these estimates, because we think measuring this stuff is useful. But we also need to be able to figure out how to produce the answers that gives us all of these statistics every time we want to evaluate a cohort definition. So I'm going to skip this. So that leads us to PheValuator. So this was the second paper that we sent out as pre-reading, and we're excited about this work as just recently got published. This started as just a little Odyssey poster a couple, I think two symposiums ago, and has now been published in the Journal of Biomedical Informatics. And what we've done here is we've developed an algorithm that will actually take any given cohort definition or definitions, comparisons of definitions, and it'll actually produce an estimate of positive predictive value, sensitivity, and specificity. And it does that through probabilistic modeling, which means that we don't have to actually have humans in the loop to manually review and adjudicate every single case. So let me walk you through the workflow of how this works. So we're going to start with an idea that we want to define, let's say myocardial infarction or whatever it might be. And you're going to start by saying, I have a cohort definition in mind. That 410, whatever Sentinel did, 410x1 in the primary position. That's the definition I want to evaluate. So my goal is, given an input of a cohort definition, I want an output which is going to be an estimate of sensitivity, specificity, positive predictive value. How do we get there? Well, we're going to do this using cohorts, just what you've learned. Specifically, or I should be careful of that word. I'm going to get overloaded on this word. Particularly, we are going to create 2 cohorts, and we're going to use them to train a model. The first cohort is going to be what Joel likes to call the XSpec cohort, for extremely specific. And by extremely specific, we mean, can you think of creating a cohort definition where you're really, really, really sure that the people actually have the disease? Okay. So for example, if I want to find all the people with myocardial infarction, I might be interested in just people who have a diagnosis code of myocardial infarction. But there's lots of reasons why that might be wrong. But if I looked at people who had 10 codes for myocardial infarction, it's kind of hard to imagine how someone doesn't have an MI if they've got 10 codes in their record for myocardial infarction. So this is a definition that we're creating which purposely finds a small group of people who we feel really, really confident actually have the disease. We're also going to create a cohort that Joel calls X-Sense for extremely sensitive, which would be saying, let's create the group of people who might possibly have the disease. And the idea there is that we want to make sure that if someone even has like a whiff of possibly having the disease, we might want to exclude them. Why? Because what we're doing is we're creating the labels that what a clinical adjudicator does definitively by saying, yes, this patient has the disease, and no, this patient doesn't have the disease. We're going to build a probabilistic model to, instead of being definite about it, to be probabilistic about it. The people who belong to the X-spec cohort, those are the people we can say, probably yes, they have the disease. So this is a noisy positive label for those groups. In the X-Sense group, what we're going to do is we're going to take a random sample out of the database. We're going to take out the people that belong to this X-Sense cohort, and we're going to be left with the people who have no possible indicators of having the disease. And I can't say that they definitely don't have the disease, but probably they don't. And what's valuable here is now I've got a set of people who probably have the disease, set of people who probably don't have the disease, and now we can turn this into a machine learning problem. Because now we could train a model that says, use all the data at your disposal and figure out what makes the people who have the disease different from the people who don't have the disease. And so we're going to train a predictive model using these cohorts as input. And then what we're going to do is now we've got this model, and this model can discriminate the probably yeses from the probably nos. We're going to apply that model to a new holdout random sample of the population, and that's going to estimate the predicted probability that a given individual has the disease of interest. So you can think of it as this random set of people. When we apply that model, the model is basically trying to determine what's the likelihood you belong to the probably yes group versus the probably no group. And what it will do is, if someone has all the characteristics that are unique to the probably yes, it's going to assign a high probability to those people. And those people that have all the characteristics exhibited as a probably no, it's going to assign a really low probability to those people. And then there's going to be people in the middle where we're just not quite sure about. And for those people in the middle, it'll assign a probability somewhere in the middle. By doing this, what we've created is a probabilistic gold standard, whereby individual clinicians don't have to adjudicate and say, yes, this person definitely has the disease or definitely doesn't. But instead, we can create a very large set of data where we've got people and we can actually assess the likelihood that they probably have the disease versus probably not. And if we have this probabilistic gold standard, then we can apply our original cohort definition we had in mind to the people in this probabilistic gold standard, and we can estimate sensitivity, specificity, and positive predictive value. Because we can, in fact, fill in that 2x2 table, our confusion matrix, and just produce these numbers as you would had we actually produced a fully deterministic gold standard. Now, it took a while for us to get this paper published, and I had a lot of skepticism in the community about it, in part because we know that that gold standard is something that requires a lot of clinical judgment to go into that. And part of what we had to think about was, how do we actually show that the estimates that are performed by following this procedure kind of get you the same answers as if you were to do it the good old-fashioned way of reviewing charts. And so I'll show you after I go through the procedure, I'll show you some of the results of that. What I can tell you is I'm trying to be precise in my language. We are producing an estimate of positive predictive value, sensitivity, specificity. We've been able to show that this algorithm that we're using provides a lower bound estimate. So what it means is your definition probably works a little bit better than we actually report it to be. But importantly, you get these numbers as an estimate, and if you are comparing alternative cohort definitions, it still is totally viable to use as a relative barometer of which cohort definition works better or worse, even if the actual absolute values you're estimating may be an underestimate. David?
So you develop probabilities for case status at the end of the day.
Yep.
See how well a given cohort definition might, discriminate between cases and non-cases.
Yep.
For those probabilities. Are we going back to having a heuristic for the simple fact that it's easy for us to report and work on? I mean, we have a model now that already is saying, like,
yep.
patients are more the likeliness, less the likeliness, and somewhere in between.
Yep.
So are we just trying to conform to what we did before?
This is a brilliant question, David. You were taught well.
Yes, I was.
It's a great question. So remember the second slide that I showed was the idea that there's two kinds of phenotypes. There's rule-based heuristics and there are probabilistic phenotypes. And today we've been focused on rule-based heuristics. And David perceptually picked up on the fact that, yeah, but aren't you just building a probabilistic phenotype to test your rule-based heuristic? And absolutely, that's exactly what we're doing. So why are we doing that? Well, because the truth of the matter is most cohort definitions that exist are rule-based heuristics, greater than 90% of them. The second thing that exists is most people need a binary declaration of a cohort definition because we currently don't have most of our statistics that can work in notions of probabilities. So like ultimately, you're either in a cohort or you're not. And the idea that you have a probability of belonging to a cohort is something that we just can't really process. And so even if you did have a probabilistic phenotype, you would be likely to then apply a binary decision threshold to say, above this probability you're in, below this probability you're out, which would still get you into the situation where you would want to quantify how well that heuristic works. Because the moment you decide to define a cut point, you're back to a rule-based heuristic.
Sure, but if you were to take, if you're going to look at the, let's say somebody was coming in for visits, and you decide the probability of them being a case of that visit, probability of that visit, probability of that visit, and you sum it. At the end of the day, you have an estimate of cases, right?
Yep.
Across an entire population. So there's still an opportunity there.
Yeah, no, you're spot on. So when Joel was working on this, part of the inspiration was some work that was done by Nigam Shah in his lab, where they were introducing the idea of probabilistic phenotyping as the goal to produce the outcome and to like find the true cases. And one of the notions about that was, well, they're not really true cases. It's more like it's a summation of these probabilities. The innovation that Joel and George and I put into this was to say, well, maybe the whole field isn't ready yet to talk about portions of people who have outcomes. But what if we could use those portions of people who have outcomes to actually say, if I've got a definition and somebody's a 60% chance of having the disease, let's give them a 60% credit for finding them, and let's ding them a 40% for getting it wrong. And by summing up those probabilities, that actually is what allows us to populate that 2x2 table and to actually estimate the positive predictive value and sensitivity and specificity. So, So the idea here, and the big takeaway that I want you to take from this paper is that we could use diagnostic predictive models as a way to produce a probabilistic gold standard. And if once you've got a gold standard, our same tricks of how to quantify false positives, true positives, false negatives, and true negatives hold. And that means we now have the ability to estimate the numbers that we want. In the interest of time, I'm going to skip over. So the basic idea is you've got all the people in the database. And for those people in the database, there's some small group of people you are really confident have the disease, and some larger group of people that's a proper superset of that who might have the disease. And then the people outside of that are the people who probably don't have the disease. And so this group in the green group here, these is our very specific cohort that we're going to create. This orange group is our very sensitive cohort that we're going to create, and yellow is the whole database as a whole. So what we're actually doing when we train our prediction model is we're trying to see, can we predict the green people from the yellow people? That's what our prediction problem is actually going to do. And on the basis of training that model, we're going to apply that model to a new set of people who didn't belong there and be able to create a reference set that we'll be able to use for our evaluation. So I'm going to just skip to show very briefly. So how do you create cohorts? The beauty of this entire approach is you just get to do exactly what you've been learning all day. An expect cohort is literally just a cohort. You go into Atlas and you create it. In this particular case, you can see I've applied an entry event of having a myocardial infarction. And I added an inclusion criteria, which was have to have at least 5 codes of the disease. Under the determination that if people have 5 codes of the disease, they probably have the disease. So this is just a cohort definition, just like what you guys have learned. Okay? And just, standard thing, you create your concept sets, you create your cohort. There is nothing new that we're doing. Actually, in the interest of time, I'm going to skip over these 2 slides. Okay. Let me actually go. This is probably worth, I'm going to take a second to try to explain this, and forgive me if I lose you. But this last point that David makes is actually an important innovation that we think we had here, which is for all of the people in your reference standard, we're not saying that they definitely have the disease or they definitely don't. We're saying that there's some likelihood that they have the disease. And so what I'm marking here is this is their predicted probability, and that's actually the observed events that they basically who got selected by the algorithm. And so the red X's there would be those that would be included in our cohort definition. And what you can see is that top one had 100% predicted probability. So that means we got it 100% correct. That is, the probability was that they had the disease. We said they had the disease, so we get credit for that. We're going to call that a true positive. This person down below, the 0, we thought the person had the disease, but our probability is 0, so therefore we just got it 100% wrong. So that person's going to be classified as 100% false positive. But the person in the middle had a predicted probability of 50%. That is, our prediction model really didn't know whether the person had an MI or not and gave them a 50-50 chance. So if our algorithm says, well, I think that person has the disease, how do we classify them as a true positive or a false positive? What our algorithm does is it actually says, let's just split that person in 2. We'll give them a 50% credit for getting it right, and we'll give them a 50% ding for getting it wrong. And we can apply this idea for every predicted probability across that entire reference set, and then just add up these probabilities to actually fill in an expected value for our 2x2 table. And we do the same thing. These are our positive cases. We do the same thing for our negative cases. It's just the inverse. If we miss somebody who definitely had the disease, we ding them as a false negative. And if we correctly classify somebody who doesn't have the disease, we give them credit as being a true negative. But on the basis of this, I've now got my 4 numbers that I care about. True negatives, false negatives, true positives, false positives. And since I've got those numbers, I can create my confusion matrix, and I can estimate sensitivity, specificity, positive predictive value. Whoops. So that's the gist of the idea of PheValuator. You pass in as an input a cohort for an extremely specific population, an extremely sensitive population. You pass in whatever cohort definitions that you would like to evaluate, and the output is actually going to be these estimates of performance. So just to give an example here are 4 different ways one could think about defining MI. We could define it as a single code. We could require 2 or more codes. We could require a code to happen in a hospital. We could require it to be a primary position. These are all random rules that epidemiologists make up because they think they know what they're doing. The question becomes, which of these actually performs best? And what we were able to do is run PheValuator against these different definitions and estimate the sensitivity, specificity, and positive predictive value of the different approaches. Just to read one of these across, we're actually trying to compare to these prior papers to give you a sense of that. So when we looked at PheValuator and looked at different MI definitions, what we were estimating in our particular Medicare database was we estimated these algorithms had a positive predictive value of about 90%. That was pretty much spot on to the published literature for those corresponding outcome definitions on slightly different databases. Now, why is it not exactly right? Well, remember, we're using different databases at different moments in time. We wouldn't expect it to be exactly right, but the fact that we're able to recover what was learned through that manual process was encouraging to us. Particularly when we then went to different diseases. We went to ischemic stroke, and we saw that our PPVs were largely in line, but we also saw that in the papers that had actually also provided estimates of sensitivity and specificity, that our estimates of them matched up to the literature as well. We saw that in diabetes as well, and we saw it in atrial fibrillation. And so whenever we were able to make a comparison of as much as we could in apples-to-apples comparison literature, we were getting pretty encouraging results. We've now applied this algorithm to a variety of different cohort definitions, and we definitely have learned that it's mixed performance. Sometimes we can kind of nail what we expect, and sometimes it's a little bit noisy due to the idea that you're learning a probabilistic model, and it's only as good as your probabilistic model is going to be. But here's a big distinction. I can produce these numbers for PheValuator for free in a couple minutes, as opposed to spending millions of dollars and many months to get the same numbers doing it the manual way. And so if you're in a choice of saying, should I do evaluation or not, I would say you should always be validating your definitions. And if you have a choice between spending lots of money and lots of time or doing something that'll get you a good enough estimate, I'd say at least think about the fact that there's now this algorithm that's available to you that uses the skills you've learned today to be able to perform that task. Yes? Oh, just because they didn't report out. What we're just doing is matching what was reported in the literature. Yeah. So, and in fact, I'll show you, in the interest of time, I'll just show you quickly, like what does the output of one of these things look like? So you run your algorithm. In this case, I've run on various different databases, run various different phenotype algorithms, and what's reported out is in fact sensitivity, positive value, specificity, negative predictive value. And what's exciting is you can see I've run against dozens of databases, or Joel has done, and I'm presenting on his behalf, dozens of databases, different phenotype definitions across the board, and I have a completely fully populated matrix of operating characteristics. The algorithm is actually able to test, or the approach is able to run whatever database we have, whatever phenotype we want, to be able to try to estimate the performance. And this tool is able to report out these statistics. To just get even one of these numbers in this spreadsheet would probably be like $250,000 in a 6-month effort. And now we actually have source code that can actually just produce that for you. This is probably the moment you should think about clapping. So that was for Joel. So what I just want to highlight is everything I'm describing here. So it is fully described in the paper, but as keeping with everything that's Odyssey, this is not just an idea. This is fully functioning code. If you go to github.com/odyssey/PheValuator, you will actually see this R package that Joel has built with an instruction manual of how you actually follow the steps. There's a chapter in the book of Odyssey that actually explains how to actually do this task. So this is now not just a futuristic idea that we had in a poster a couple years ago. This is now a tool that we actually feel strongly should become part of all of our collective best practice. And the idea that now you have a tool, you don't have an excuse for not producing an estimate of sensitivity, specificity, and positive value. And once you guys are now starting to evaluate your definitions, now, different people with different ideas about how to define a disease have a tool to actually compare those things. So now we actually have the ability for each of us to come up with our own approaches defining diseases. And now we have a tool to actually figure out which of those approaches make sense in the context of your data or my data or the data across the entire network. So with that, I'm going to shut up. I'm going to thank you guys for participating in today's cohort tutorial. Hope you guys found it to be useful. We are going to be sending out a survey. Actually, I think probably 2 surveys. So one survey very narrowly is going to be for you to provide feedback about this class, about what myself and Chris and Kong presented to you. You'll also receive an email specifically to collect additional data on criteria to query. Are we doing that, or did you have it do it in?
We already distributed the post-workshop feedbacks, the survey, so if anyone haven't filled out
So if you got those forms, we'll make sure to pick them up. But we would really welcome some feedback on the class itself. So you'll get an email, and if you could fill out that form, that would be wonderful. I know that we need to break down the room, but I'll just see any burning questions, thoughts, suggestions of how we could not suck next time.
So how long did it take to make that extension? You said to get just one value, it takes 6 months.
Yeah, so running the code, like that is the standard output of the code. So it's basically as long as it takes to run the algorithm to produce numbers. But like order of magnitude, we're talking minutes or a couple hours, not months or years. Yeah.
Can you publish the JSON for the correct answers for the studies?
Yep. Oh, yes. Oh, yeah, I'm sorry. So since we didn't get to those trials we did, actually, Kong, can I actually ask you to take on this? Let's make sure that we share with the class the JSON for the tutorials that are like the gold standard so that people can compare.
So all of you will still have access to the tutorial website, the Atlas instance on tutorial for these few days, right? So we're
Yeah.
going to answer or
Yeah. And we'll move. Let's move it onto the public Odyssey one so that it doesn't disappear in 2 days. Yeah. Yeah. Yeah, so this idea of like other ways to get ground truths is a really interesting area of focus, and we haven't, we're investigating different ways, but right now we haven't been trying to use clinical trial data, but it's a good area to focus on. All right, thank you guys very much. I appreciate you're putting up with us.